Good evening, Aruna ma'am. कोई बात नहीं, आप muted हो. Hello.
Good evening. Good evening, Dr. Anjana, Dr. MP, Dr. Seema.
Good evening, ma'am.
Good evening.
Hi. Good evening.
अरुणा जी
Good
स्वाति
evening,
आंटी,
Dr. Parimala.
नमस्ते नमस्ते।
Good evening, ma'am.
Good evening.
Dr. Sumita has also joined. Hi, ma'am.
Hi everyone.
Hello, Dr. Samita. So we will be starting sharp at 7. Hello,
Yeah, it's
Dr.
almost
Patil.
7.
Good evening. Good evening.
Good evening, sir.
Yeah.
So, Dr. Aruna, shall we wait for 2 more minutes before starting?
Okay, 2 more minutes and then we'll start.
Okay.
Dr. Anjana, can you just type a message in the ISCCP group said that we have started? Kindly join.
Okay.
So, Dr. Aruna, I'll just start.
Yeah, please.
In the meantime, you can join. Yeah. So, good evening, everyone. Welcome to the monthly webinar of ISCCP, which has now become a great hit amongst everyone. And I think every month we look forward to having this special session, 7th of every month for 70 minutes. And it's heartening to see the overwhelming response today. Also, hopefully, a lot of people will join. So today's webinar is focused on a very important topic for India, which is VIA. Where does it stand? And we have a very interesting panel discussion on managing of cervical intraepithelial neoplasia in special populations. So without any further delay, first and foremost, I would like to invite Dr. Aruna Nigam, President ISCCP, to say a few words. Welcome, ma'am.
Okay, thank you, Dr. Bindia. So the topic has been introduced already, and we are having really a very good response for our monthly webinar, as well as for our colpo training, as well as vulvovaginal training. So just to announce few things, I'll take only 1 minute for the same, that we are going to have lectures on the vulvovaginal module, which will be starting from 12th of September. So anybody who wants to register for this module, that is a V-Insight module on vulvovaginal disorders, can join before that. That will be better, so that you will be attending all the lectures and having a training on the same. The information for the same has been uploaded on the website, that is isccp.in. So any information, any recordings you want to watch, you can go to our website, which is very much live and active. If you find any problem, you can communicate to us in the group or personally also. We will be happy to take all the problems which you are facing. The second important thing which I want to announce, that we have launched the HPV vaccination module, training module on 1 month back, and we are having a very good response. So once again, this is a free module for everyone, which is having a lecture as well as MCQ of around 1 hour duration, and whatever queries comes in your mind is there in that module. So please go through that module and have a certificate from the ISCCP. The link for the same is also available on the website. Otherwise, you can go to isccpacademy.in. I will once again post this link on the ISCCP group. I will encourage all of you who is not from the ISCCP to become a member to avail various opportunities which are there in the by the ISCCP. Like we have started the credit point system for the public forum CME workshop by ISCCP. Any informative program which you are organizing, ISCCP is going to give you a credit point for the same. And once you have points more than 10 or 20, depending upon the workshop or the public forums which you are conducting under the banner of ISCCP, you are going to get some kind of reward, because these are the community works which need to be appreciated by all of us. So, and it takes a lot of efforts to organize these type of public forums, vaccination programs, or CMEs, or hands-on workshop. So don't lose the opportunity and do the things under the banner of ISCCP. Information regarding the same is also on the website. So please visit the website. And without any delay, I hand over the mic again to Dr. Bindya. Thank you all for joining.
So thank you, Dr. Aruna. So now let's start the session. I now invite Dr. Seema Singhal. She is a senior resident in Obs and Gynae in UCMS and GTB Hospital, one of the colposcopy trainees also with us. So welcome, Shirin, and she'll be the master of ceremony with us today. So welcome, Shirin, and please share your screen.
Thank you, ma'am. Thank you for this opportunity. So without further ado, I would like to start the webinar for today. Ma'am, is my screen visible?
Yes, it's visible.
I would like to invite our chief. Yes, ma'am. So I would like to invite the chairpersons, Dr. Sumita Mehta, ma'am, Dr. Seema Prakash, ma'am, and Dr. Anjana Sabarwal, ma'am. And the speaker for today would be Dr. Seema Singhal, ma'am, who will be talking about where does VIA fit now and future prospects. Dr. Sumita Mehta, ma'am, is a senior specialist and in charge of the Department of OBG in BJRM Hospital, Delhi. She's a vice president of ICR 24 to 26 and a national expert for the project for ECHO in Noida. Ma'am has edited 10 books and more than 70 articles, and she has special interest in preventive oncology and high-risk pregnancy. Dr. Seema Prakash, ma'am, she is a fellow of the Indian College of Obstetrics and Gynecology, and she is also a professor at the Department of OBG in GTB Hospital. She's a president of NAMA Association,
Shirin, I
National
think that's
Association
okay.
of
We
Mentors
know
for
each other.
Adults.
Shirin, thank you. Thank you
Okay,
so
ma'am.
much. Yeah, thank
Yes,
you.
ma'am. Dr. Anjana Sabarwal, ma'am, she's a senior consultant and obstetrician and gynecologist in Prime Hospital, Ghaziabad, and she's also a FICOG faculty. Dr. Seema, ma'am, who's the speaker for today, she's a professor and a consultant gyne-oncologist at AIMS, New Delhi, and she has received multiple awards.
Stop your screen share, Shirin, please.
Okay, ma'am.
Dr. Seema, you can share your screen.
Sure, thank you. Visible?
Yes, it's visible.
Right, so now let me make it a screen share again.
Full screen.
Full screen, yeah. Is that okay?
Yes.
Yeah. So first of all, before I start, thank you so much, ISCCP, Dr. Aruna, Dr. Bindya, Dr. Sumita, and Dr. Anjana are there. Thank you so much for this opportunity for having me here today. So I'm given a very interesting topic today, that VIA, the current and future prospects. So let us understand where does it stand today for all of us. So I'll start with that notion that as of our understanding, as we all know, the cervical cancer screening remains an unmet need for our country. The data shows that only 22% patients underwent a cervical examination at any point of their life. Only 1.2% patients were screened as per the 2020 NFHS 5 data. This frequency of screening varied based on the region. If you look into the northern region, Punjab, Chandigarh, Himachal Pradesh. Then east and west, if you look into Maharashtra and Odisha and Goa. Central and northeast, Mizoram, and in south, Tamil Nadu, Andhra or Kerala, or even Puducherry. There are few states which were outshining the others, but there are some where there's nothing. And look at ourselves, 0.5, 0.2, 0.3%. This is how we are, even in Delhi, standing in the capital of our country. Why is it happening? Knowing, yes, is a major problem. But even if you increase the awareness, in the study, 34.5% patients, despite being aware, only 9.5% underwent. So, lot of problem, knowing doing gap, and there is no data, no protocols for adherence to treatment recommendations. So, these are the major deterrents. This is a meta-analysis which was published in 2022, which showed huge barriers like individual, social, cultural, health system, and structural. So today we talk about the health system and structural barriers, like lack of policies, guidelines. They are there now, but lack of trained staff, resources, materials, equipment, poor attitude of staff, and poor planning from our side, long waiting times, and exclusionary policies by age or marital status. Patient unmarried, even if she's 40, little bit, kind of deterrent that she's unmarried, she's come for cervical screening. Why? All these, that these are the main barriers in our country. Structural barriers like financial constraints, unaffordable screening cost, transport, cost, service unavailability, accessibility, remote services. So these remain the major barriers. So WHO recommends all screening modalities, including molecular, cytological, and visual inspections, depending on our availability. So before we actually want to roll out something for our country, we need to understand that we need to screen 511.4 million women as per the latest HPV Information Center fact sheet for cervical cancer. And if we want to meet this 90, 70, 90 targets, then 70% of these need to be screened by 2030. So it looks like a huge task, which is very difficult to meet. So the history of India has been that in order to choose which screening modality we want to use, we have always been catching the low-hanging fruits because that is the only feasible option that we have. So we had a lot of research done in our country, including 3 randomized control trials and 11 cross-sectional studies. So this is a meta-analysis systematic review which showed after the reviewing these 11 studies which were conducted, the major well-designed, well-planned studies, which included approximately 313,000 women from urban and rural settings, and VIA performed 16.6 to 82.6% was the sensitivity and 82 to 96% was the specificity, which was very variable depending on the observer, depending on the performer, and the cytology and HPV testing was also comparable. With the best of the hands, they were comparable, but with the lack of a trained professional, it tipped. So the three randomized control trials, Mumbai, Osmanabad, and Dindigul trial conducted by Dr. Shankar Narayanan and Dr. Nija, these all trials showed that VIA-based screening can reduce cancer incidence and mortality, and cost efficacy is definitely there in India. And with this single round of VIA, it had a potential to reduce mortality from cervical cancer. So with this, even the meta-analysis also confirmed the same finding. So VIA emerged as a promising tool for LMICs. Why? Because this is the only test which empowers clinician being true point of care test. You just put the reagent and the results are there. So it empowers as a clinician. And so it aligns with our mandate of screen and treat approach. Sensitivity and specificity were comparable to cytology-based screening. I just showed you the results. The cost was really low. and it can be done by a
दरवाजा बंद कर देना
workers after 5 to 10 days of training. And it had a potential for reducing death by 31 to 33%, and a single round was also good enough to reduce the mortalities and the incidence of invasive disease. So by virtue of this, even though our latest Foxy GCPR recommended that if HPV test, affordable test was not available, VIA is the test to go every 3 to 5 years, starting from 30 to 65 years. But before we actually go in, we need to understand that VIA has a huge potential for overtreatment and undertreatment. So, VIA would lead to missing more cases. That is a little bit dangerous for us. And also, studies were conducted to know why it is happening. Entirely, it was seen that the patients who were elderly, where there was cervical inflammation, and where the gynecologist had less years of experience, the chances of missing the test was more. So the trust was a major question, and so were the limitations of low specificity, being subjectivity, limited accuracy in postmenopausal women, variable test performance, and difficult quality assurance standards. So these were considered as major limitations. And then thereafter, a very systematic program was introduced in Tamil Nadu state in 2007, where they scaled up this very, very well organized screening program using VIA for cervix in to 32 districts in a very, very phased manner, and opportunistic screening was provided. And this program was linked with Chief Minister's health insurance scheme, wonderful linkages with treatment, with the single referral centers, and very robust program with good IEC incentives, sensitizations, local languages. All these issues were covered, and it was implemented across the state in a very phased manner. And they found out the average cost per women screened turned out to be only 70 rupees, almost $1 as per at that time. And it included all those things. Recurring expenditures also were there, like salaries and resources, and all those things were also included in that 70 rupees cost. But when the data analysis was done, it was observed that when compared with the Osmanabad and Dindigul trials, which were done in a strict research setting, what happens in the programmatic setting with using VIA? They targeted a huge population, approximately 1,43,000 women were screened in this program. Screening rates using VIA was 3.8%, which was much lower than what was done in the research settings. Compliance to colposcopy was only 47%, which was approximately 98% in the research setting. Biopsies were possible only for 35%, and CN2 plus detection rates were only 0.5 per 1,000. So, which was a very, very, setback for VIA. And furthermore, it was felt that huge investment will be involved in follow-up and treatment. So the lessons learned: adequate political and administrative support is required for implementing a VIA-based program. So we need to strengthen our healthcare infrastructures. We need to train our healthcare workers. Awareness, loss to follow-up, geographical barriers, and compliance need to be addressed in a collective manner. So doesn't look like very easy, and so it was felt that VIA does not look like our cup of tea if we want to do it a programmatic setting. Meanwhile, all over the world, molecular tests were introduced, and even WHO said, if possible, everywhere, introduce a HPV-based program because of the rigorous research that were published, and we all are aware of those developments. So, but then, is it possible to introduce molecular tests for all the countries, including ours, in similar LMICs? Because of the lack of initial investment. See, if we want to invest too much into this, do we have it? Our ministries and our government is not that sensitized that they will introduce a molecular test all over the country in those hard to reach areas as well. So this although the concept is that if you do this initial investment, the kind of strengthening of and lengthening of the screening intervals to 10 years, the HPV-based programs are providing, it's going to overcome that cost. But still, initial cost investment is difficult. 2, high rates of positivity because it's a highly sensitive test. So a lot of positive cases, are we ready to bear that colposcopy burden and treatment burden as of now? So this was a meta-analysis which was published by our friend Dr. Rupa in the JCO Global Oncology, and it very nicely, very structurally showed us the challenges in implementation of HPV self-sampling program across the country, like lack of healthcare provider issues, health system issues, and beneficiary issues. So I'm not going into details of this as of now because of time constraint, but just to summarize, that lack of knowledge, lack of privacy, refusal for screening, motivation, long waiting times, complexity of HPV devices, lack of incentives, same things, overtreatment, lack of training, poor communication skills, all these things together are currently providing a great challenge to the ministries to implement the HPV-based self-sampling programs. So are we really ready to implement the molecular testing? So in this kind of a scenario, does VIA still holds a place for our country? That is the question that we need to answer. So WHO guidelines in 2021 gave us two options. Either one, like in our country, when DHPV DNA yet is not yet operational. So we have to still consider VIA. Two, if we are doing at HPV testing also, triaging of HPV positive women to avoid unnecessary colposcopy using VIA is a great option. So these are the two very important roles that WHO recommended us. First, implement VIA testing, and they have given us a wonderful algorithm how to manage, how to identify VIA. VIA is a very powerful test. I said it is a true point of care test. You apply the test, you will come to know that yes, the test is positive. And it is not looking like a cancer, so you can rule out cancer. And if it looks like a positive test, you can find out if my patient is eligible for ablation or not. If yes, go ahead, do ablation, done, story finished. So, and you can also find out the lesion is going inside. So I cannot treat her, let me refer her, go ahead. So, same screen and treat approach, you can do so much. It goes well for both the general population and the women living with HIV. So, and then VIA triage, because it helps us two ways. Number one, it helps if a patient is like HPV positive and we do VIA in her right away in the point of care test. So we will find there's a large lesion, it looks like cancer, refer. Doesn't look like cancer, you can manage, ablate or excise, refer. Harms, yes, even if you do a VIA triage, you're reducing the sensitivity of your HPV test. Right? So WHO gives us this excellent algorithm. We all have read that, how to go away with it. Right? So now, this study, E-Stamper study, that this was a major multicentric study done in European countries, multicentric study, including 3,142 participants. So they wanted to see how VIA performed for HPV positive patients. So in this particular study, they found that women aged 30 to 64 years, when they were HPV positive and they were triaged with VIA, how did they perform? So we can see that the interpretation of VIA varies by age. Patients less than 50 versus more than 50. Great difference. So less than 50, 80% lesions were detected. And differences by age were found non-significant for CIN2 plus lesions, but yes, specificity was significantly higher for women who were more than 50 years. And positive predictive value was 6-fold higher than those with negative VIA results. So risk of CIN3 plus among VIA positives doubled the risk of CIN3 plus in HPV positives. VIA almost halved the referral rate in women less than 50 years and reduced the referral by almost 2/3 in older women. So this was a great finding, and they, substantiated, yes, we can do it. And also, additionally, they also tried to find out how would be the performance by stratifying based on the examiner's experience. So the examiners who had experience less than 50 VIAs, they performed really bad by reducing the sensitivity of the test. However, the examiners who had great experience, they performed very well and had an excellent specificity and sensitivity. So the range of the sensitivity and the performance varied by the provider. For example, if you look into it, sensitivity 25 to 95% based on the years of experience or the number of VIAs that were performed by the examiner. Specificity, positivity, everything, so much variable, 0 to 98%. Just imagine the confidence interval. So they felt that VIA sensitivity among HPV positive women performed by trained providers was high and led to an important risk reduction in referral rates. Scaling up HPV screening triaged by VIA will be challenging due to high variability of the performance and providers' need for training and supervision. So, the subjectivity of the test and the need for training and quality control, and this made a challenge to introduce a VIA-based program. And there's limited health information systems, difficulty in tracking, screening, treatment, and follow-up outcomes. Because with molecular test, you have a system. With these subjective tests, VIA-based tests, we don't have HIAs. Treatment constraints are there, and follow-up gaps and sustainability issues were there for this. So, but then this is a recent meta-analysis which was published and which again found out various studies, and they showed that performance of VIA improved within 80% of the pooled specificity and sensitivity. Then WHO gave us these quality assurance standards. So if you see, then monitoring for the quality assurance standards for the VIA-based programs, I mean, excellent standards, I love reading them. The low specificity and the suboptimal performance of VIA. Yes, where we have a risk of overtreatment and undertreatment. So these standards are crucial in maintaining uniform and reproducible criteria for test positivity and ensuring that the provider conducting the screening test accurately differentiates. How did they come? Interestingly, they shared a success story of Bangladesh. So what happened in Bangladesh in 2004 to 2005, they found that they did a pilot work and found out that VIA was working for their district. And then they upscaled this program from 44 to countries, for at least 64 districts were involved. So the test providers and colposcopists in the project, they were trained, retrained. They were given pictures for refreshing their trainings. And they also, based on their data, they made these quality standards that yes, this much should be the positivity, this much should be the treatment rate, this much should be the detection rate, and so came these standards. So the purpose of these standards is to ensure high quality of care with VIA. They gave us very discrete measurable indicators to clearly define and facilitate assessment of program performance, improving performance to meet expected standards. For example, look at this. The core indicators for program monitoring, that we need to screen women 30 to 49 years annually. VIA positivity rate should be 5 to 10%. Treatment rate should be more than 90% and coverage more than 70%. So this was feasible in their study, and based on their data, they gave us these standards and they gave us these kind of results. For example, they have to number of new cervical cancer screenings every month the person has to do in their setup, and positivity rate, single visit approach rate, and then you have to see that like a partogram you see in your obstetrics, that you would have that you are approaching those standards or not, you're not approaching those standards. So they give us annexures like that the nurse who's doing it can have a report based on these templates and action plans, how to do a corrective measure for improving our performance of VIA. So factors, they also identified the factors which may affect the VIA performance, like provider training, quality of life, acetic acid concentration, workload and patient age, supervision visits, self-assessment, client feedback, and use of mobile and digital cervicography. I'll come a little later on these issues. So screen and treat approach recommended to minimize loss of TOS2 follow-up, and with these supportive supervision and HIS data systems, and that they are recommending a continuous quality improvement is feasible, and this kind of standards may help us to integrate VIA into our national programs till we are robust enough to implement the HPV-based screening in our country. So these are the summaries of proposed core indicators. Don't worry, I'm going to read these just to show you that this is how they have given us the numerators and denominators and the frequency of each, like screening rate annually, how much you have to do. So, and then similarly, percentage of VIA screening, you have to mention in your data annually that how much are you doing. So similarly, they gave you these kind of treatment rates and coverage of target population. So now with this, can we further improve the performance of VIA? This should be our aim as a gynecologist. So there are few measures that have been devised, like digital photography or cervicography. For example, after you do a VIA, an on-site healthcare provider can use a camera or to photograph the cervix and can send the digital image electronically to a supervisor who can read these visits, and we can kind of see the concordance if it is matching. Like And also, the program managers and supervisors can develop electronic tools such as VIA-based image banks on a regular basis, and providers can, brush up their knowledge using these image banks. And this was used very well in Bangladesh studies and also in East Tampa study as well, this kind of protocol. So if we use these kind of protocols, can we improve our standards? So, and then there were more advancements. If you see into VIA, there were few advancements that I'll be covering in next 2-3 minutes. And so VIA will be, they connected VIA with this modification of using a magnifying lens mounted with a battery operated light emitting devices. Simple light device mounted with a magnifying device. With this, they found that it is better. You will be able to see the lesions better without any needing much cost or anything. And they found that sensitivity improved from 57 to 100% using nurses. And specificity was 99 to 89. It obviously it will reduce a bit, 99 to only 89.5%. And it was able to identify even 21 patients out of 32 cases of chronic cervicitis. See, while you're interpreting VIA, as I showed you in that data also, chronic cervicitis is a major deterrent. It leads to a lot of false positives and overtreatment. So you are able to identify 21 out of 32 cases of chronic cervicitis by using this device. So it looks like quite a promising tool for us. Now, then again, they tried to connect VIA with a smartphone-based device, which is going to see properly, to magnify it properly, and they found that it has an excellent discriminative power as compared to the naked eye examination to detect precancerous lesion, and thus can have an additional armamentarium in our hands. Then came the role of AI. As into every field, why not VIA also? So they tried to compare the AI based tool. It is our own Indian study, which I'm trying to show. And then there was a meta-analysis also, which was done with the available studies. And they found there was a significant improvement in the performance of VIA using AI-based VIA tool, which they validated in their study. First they developed and then they validated this, and with an accuracy of 76%, but still they remained a false positive of around 20%, which is not less for our country. So these are the various studies which showed that VIA performed better after integrating it into the AI. So this looks like promising and looks like future of our VIA based screening. So available results and data show that quality of modifications of VIA images is satisfactory, has a potential to enable the important cases CIN2 plus diagnosis, including smartphone and AI. And these algorithms have some potential to take forward for us for further research and for future implementations. So I would like to conclude by saying that VIA remains as a simple, affordable, and a true point of care test in hands of clinicians, which is suitable for low resource, and not only low resource, for every setting, including hospital. If you are doing an HPV test, it is useful in your hands. You can use an screen and treat approach. So this is a true test which is going to help us go ahead with the screen and treatment approach, overcomes many limitations of cytology. But yes, it has its own limitations that we discussed just now. So, but then by using these new technologies, can we overcome those subjectivity and lower specificities? So this remains a food for thought for us. And in the WHO elimination strategy, VIA will continue to play a complementary role along with HPV DNA testing, especially when access to advanced tests is limited. Thank you so much for your patient hearing. And I would like to, I'll be very happy to answer the questions if any. Thank you so much.
Thank you, Dr. Seema, for such an insightful talk, and it was excellent and beyond words. So over to chairpersons for their comments.
Yeah, it is. Dr. Seema has really covered everything about VIA. Only one thing I want to know, what is the role of AI in VIA? Like, can you elaborate on that?
Yeah, see, initial studies that have been done with VIA, what was done is that they would take pictures of their VIA positive, negative cases, train the AI tools, and then validated their study. So then they compared the ROCs, AUCA, area under curve, sensitivity, and specificity. So if you see into that, then if you see colposcopy remained the gold standard, it performed the best. But as compared to naked eye visual examination, when visual examination was combined with AI, the area under curve improved for this algorithms. So it has if you have already a phone or something which has AI based images, you put your image into that and your phone will tell you you're positive or negative. So in that
Like if I
situation,
put my image on Chat
yeah,
GPT, now I am
not
taking a
chat
VI,
GPT, exactly. That's
then
not
then
not that kind of
then
a
what? Then
scientific,
what?
no, no, scientific and validated tool. Chat GPT is not the right approach for that.
Okay, okay,
So that's not the good idea. So you will have
okay.
your phone or something, you will have a software which will show you that this is a VIA AI based tool, right? So
So
you will have that in your phone, and then you put your, suppose you do a VIA, you say it is positive, and you have a doubt whether it is
yeah.
positive or negative, then your VIA based AI tool will tell you it is positive or negative. It is a scientific tool. So then you will have, okay, so good, I said positive, it is positive. So it increases your sensitivity, something
Okay.
like that.
So do we have any Indian-based AI?
Yeah, Dr. Usha Rani police study. They did something,
Okay.
you just go and see that study. And Dr. Usha Rani police, our own gynecologist, who's been working so well last so many years. So you can contact her. Yeah.
Oh, fine. Thank you, Dr. Seema. It was really elaborate and very like VIA is basically very good tool for countries like India, and we should promote it as much as possible. So thank you very much, and thank you, Bindia, for inviting me, Dr. Aruna Nigam. Thank you so much.
Dr. Seema, it was a very comprehensive overview of VIA. And as usual, your lectures are always very informative. And that's what I want to impress, that VIA actually is the answer for our LMIC, for our
Yeah.
country. And it's very heartening to see. I do quality assurance standards. I go to different villages to see that. And what was heartening to see was that even in small health and wellness centers, right inside the villages, closer to the community, they are doing VIA. It is being done by CHOs who are say sisters or even Ayush practitioners. So the ones who are managing these health and wellness centers, they know about VIA and they are doing VIA. It was so heartening to see, every time I ask this question, are you doing VIAs? And they say, yes, ma'am, and they know how to do it, and they're picking up cases and referring to their PHC. So that is how I feel that this point of care test is the answer for our country, and it can really work. If we somehow formulate a framework district wise, if you are able to go and do something about it, maybe it can work wonders. So
Yeah, Dr. Sumita, here I would like to add one thing. Only recently I came to know that even Directorate of Health Services in Delhi, they are training their people, like the medical officers are being trained free of cost for via VD. So they have this module in their mind. I don't know the detail of it, but only last week I came to know about it,
So
that
I
they
tell
are
you one thing here.
making it, yeah.
Recently, our one of our colleagues, you must be aware, Dr. Palvi Shukla is there. So she's doing one ICMR, a huge implementation project she's doing across the district. And ICMR did not fund for HPV; they funded for VIA only. So, abhi bhi government of India has not yet changed their operational guidelines. They're not yet ready to change their operational guidelines and not kind of coming out of VIA. As of now, I don't know about tomorrow. What is happening inside, I do not know. But as of now, as a person, I know that still we have our guidelines as VIA as of now. Yeah.
feasibility also in our country is more for VIA than for other,
Yeah,
HPV tests.
Dr. Anjana, last comment from you.
Congratulations, Dr. Seema. It was a very wonderful talk, and you very clearly told us the recent advances which we can use with VIA. And as you know, visual inspection of cervix with acetic acid VIA is actually a VIA media, as you also highlighted. It is a two-way thing. Either we use it as a primary tool for screening, or if HPV positive patients have come, we can use it as a mode of secondary confirmation of the diagnosis and the confirmation of the place from where we have to take biopsy. Best part about VIA, as you have highlighted, is that this is something which is very cost effective and suited for our country setup. And secondly, not much of training is required. But I would still say that if we go through the ISCCP website where we posted the various via pictures, if we go through them, most of the people would be able to, garner full excellence as far as interpretation of via positivity or negativity is concerned. So thank you, Dr. Seema. Thank you so much for telling us about use of this simple technique in a future with the help of artificial intelligence. Thank you.
Thank you, ma'am.
Thank you, team ISCCP, for giving me the opportunity to chair the session. Such
Dr.
a
Anjana,
brilliant
you
session.
are ISCCP team only. So, yeah, so thank you very much for such an excellent session, all the chairpersons and Dr. Seema. So now, Dr. Shireen, we have will now introduce our next very, very interesting session, a very interesting panel discussion moderated by Dr. Nilanjali, and we have a galaxy of panelists. So, Dr. Shireen, over to you.
Thank you, ma'am. We would like to start a panel discussion.
Please share your screen.
Yes, ma'am. We would like to start the panel discussion, which is for screen positive and special population. Our moderator would be Dr. Nilanjani Singh, ma'am. She is an associate professor at AIIMS, New Delhi. A clinical fellowship has been done by her in gynec oncology from Canada. She's a gynae oncology group fellow from USA and a member working group of International Papilloma Virus Society. Ma'am has done multiple publications and she has done a lot of research projects. Our panelists for today would be Dr. Rimpi Singla ma'am. She's an additional professor at PGIMR Chandigarh and her areas of interest include cervical cancer screening and management, high-risk pregnancy and safe use of antibiotics. Dr. Nidhi Gupta ma'am, she's also an associate professor. She's done MBBS, MS, DNB, FAMS, FICOG, MRCOG, and she's done her senior residency from Safdarjung. Ma'am is a joint secretary of ISCCP and a member oncology committee, AOGD. Dr. Pratima Raj, he's a consultant gynae and a gynec oncologist, laparoscopic and robotic surgeon, and a member of various committees. Dr. APJ Abdul Kalam Inspirational Award is also one of his major achievements. Dr. Priyanka, ma'am is a consultant gynec oncologist in Indus Hospitals, Vishakhapatnam, Shakti Women's Wellness, Vishakhapatnam, and an ISCCP certified colposcopist. Dr. Pinaka Mamsi sir, he's a consultant and in charge of the gynecological oncology, and he's working currently in Homi Bhabha Cancer Hospital and Research Center, which is a unit of the Tata Memorial Hospital of Mumbai. Dr. Jitendra Pariyar, sir, he has done his MD OBG from Nepal, and he has various publications and an award in the AOFOG YGA in 2009. He's currently a gynec-oncologist in BP Koirala Memorial Cancer Hospital. Over to you, ma'am.
Thank you, Shireen. Can you please stop sharing? Yeah, at the outset, I would like to thank IHCCP, Dr. Arna Nigam ma'am, Dr. Bindya ma'am, Dr. Sumita, Dr. Shweta, Dr. Nidhi. Thank you for giving me the opportunity to talk about such an interesting topic. After this very, very amazing talk by Dr. Seema, we are going to panel discussion on screen positives in special population. Let me share the screen. All right, is my screen visible?
Yeah, Nilanjali. Yes.
And is it now on full? Yes,
Yeah,
full
it's
screen?
visible.
Yes. So screen positives in special population is what we are going to have a panel discussion upon. So yeah, is the slide moving?
Yes, Nilanjali.
All right. So as we all know,
I will just request everyone to mute themselves except for the faculty because it is very disturbing. It is and between we cannot hear clearly. Okay, Nilanjali, yeah, proceed.
Yeah. So as we all know, cervical cancer is so common. It's a cancer which is related to so many deaths among women in LMICs, including India. And ISCCP is working a lot on elimination of the cervical cancer. And this is the first time that the world has committed to eliminate a cancer. So for this elimination, there are various levels of prevention: primary, secondary, tertiary level of prevention, and palliative care. And here we are going to talk about the secondary prevention, which is screening and treatment of precancerous lesions. So we all know the guidelines of cervical cancer screening given by various bodies. The WHO says that screening should be in the age group of 32 to 49 years, and it should also go on to 50 to 65 years if we have facilities. And they recommend primary HPV as the screening modality, which should be done every 5 to 10 years, and cytology or VIA every 3 years is also acceptable if we don't have facilities for primary HPV testing. And it also says that there are screen and treat approaches, there are screen, triage, and treat approaches. And WHO also says that we have to use triaging by partial genotyping, colposcopy, VIA, or cytology, depending upon the availability. And this is in general population. However, we are going to talk about special population. So rather than wasting time, I'll go on to these cases on a case-by-case basis. We'll have case scenarios and have discussions on them. So first case, I would like to talk about a 32-year-old lady, para 2, live 2. She came to OPD with discharge. She is HIV positive and her CD4 count is 800 cells per cubic millimeter. Now, on speculum examination, cervix otherwise looks healthy apart from this discharge. So there is an evidence of infection, and a pap smear was done, which shows ascus. So my first question goes to Dr. Jitendra Pariyar. Sir, what would you like to do in this case? She is a 32-year-old, HIV positive, PAPS shows ascus.
Thank you, Dr. Singh, for giving me the opportunity to discuss on this case. Well, we are discussing on high-risk population, which is little bit different from normal general population. So in this particular case, 32 years old with HIV positive and immunocompromised state, and we have the cytology report of ascus. So next would of course be triage her further, probably with colposcopy and also with high precision test, especially in HIV immunocompromised clients. We would not like to miss the infection and the lesion. So probably test with HPV DNA and colposcopy trials also would be sensible.
Okay, so did you say colposcopy because she's an HIV positive? Because Dr. Jitendra, in ascus, otherwise the routine recommendation will be to go ahead with the HPV triage if we have a facility. So do you mean that in HIV positive, we should go for an HPV test or a colposcopy directly, even if it is ascus?
More would be, of course, to follow the regular pattern,
right.
The HPV DNA test, and then plan for colposcopy based on the report.
Okay.
But this would definitely be a candidate for further trials, careful trials.
Yes, I completely agree. And then most of the guidelines here, like you're seeing in WHO or the ASCCP, all the guidelines and even our own FOXI guidelines, they'll talk about doing triage with HPV test in cases of ascus. And the same goes for an HIV positive women. And we have gone through these charts again and again, and we all know that if HPV is negative, we can go ahead with routine screening. However, if it is positive, like Dr. Jitendra is saying, we can go ahead with colposcopy. Now, very important points to discuss in HIV positive women are that what are the risks of cervical cancer and precancer in HIV positive women? Are they same or they're different? And if they're different, like how is the screening different in HIV positive women? Dr. Jitendra.
Well, since these are immunocompromised population, we kind of evidences have shown that persistence of infection is there and progression is more rapid.
Right.
So instead of like 5 to 10 years of duration for normal population who have tested negative, these population, we need to shorten the duration of second subsequent screening. So, so most of the guidelines say 3 years, and in Nepal also we follow our national guideline also recommends for at least 3 before that. That is one. The other is like since these population if, tend to have persistent and progression more rapidly, we recommend them to be tested even beyond, recommended age of 65. They should be kept on regular, screening, shortening the screening duration. And of course, regarding the test, which we have various tests available. Among them, we would recommend high precision test, which of course is HPV DNA.
Great. Yeah. Yeah, I completely agree. And then WHO talked about newer evidence on cervical cancer screening and treatment for women living in HIV. That was a document which was there in 2023. And some of the changes which are there from routine screening is that unlike in a normal population where screening starts at 30, or even, for example, ASCCP says that screening starts at 21 in their population. However, in HIV positive women, the screening should begin at the onset of sexual activity, irrespective of their age. So even if it is earlier, we can start screening them earlier. And it has to continue throughout a woman's life, even after the age of 65, like you were saying. And primary HPV DNA, like you're saying, is a recommended test, which has to be done at shorter intervals, that is 3 to 5 years, unlike 5 to 10 years in normal population. And triaging is very, very important. We cannot do screen and treat approach here. We always have to triage. And for triage, HPV 16, 18 genotyping, colposcopy, cytology, or VIA, depending on the facilities available, we have to go ahead with the triaging also. And if HPV test is not there, of course, cytology is something which is, again, the primary screening method. And it is very, very important to note here that the screening test should be integrated with the HIV test. We know that we have such a robust HIV care program for our HIV positive people. And these HIV positive women who are already following up there, integration of screening into HIV care will be very, very positive step for these women. So another question will be, Dr. Jitendra, that what is the impact of CD4 count on, a screening, or do you think we should screen, or is there any evidence which says that CD4 count has an impact on development of cancer or precancer in these women? And how does the heart, that is the ART they are receiving, that impacts management of these women? Anything you would like to talk about that?
Well, of course, CD4 count reflects the immune status. So immunocompromised status would mean that more chances of a persistent disease and more chances of progression. And to some extent, heart could kind of prevent that. So could have a positive, outcome.
Yeah. So CD4 count, so there's evidence that more than 350 CD4 count, well, that population, the progression rate is almost similar to normal population, but when the CD4 count starts falling, in those cases, the progression is really, really high. So, well, there are no guidelines, there's no consensus how to screen it depending on the CD4 count. However, the evidence is very, very clear that with lower CD4 counts, the progression to precancer and cancer is very high, and that population should have even more stringent screening. And as far as heart is concerned, so ART, well, in a systemic review, it has never been shown that, yes, it improves the progression or something, but yes, it does have an impact on a CD4 count, which indirectly helps in lowering the progression of HPV infection to precancers and cancers. So that is where the role of CD4 count and heart lies. So, like we already said, the role of screen and treat approach in women with HIV is not there, and WHO has always said that we have to do triaging also. Now we move on to the next case scenario. Dr. Pratima, this case is for you. A 71-year-old female, postmenopausal, para 3, life 3, with vague abdominal pain, everything else normal, cervix appears healthy, vagina appears healthy, but she came with an HPV report of HPV being positive. No genotyping done, but just HR HPV being positive on cervical cancer screening. So what should be the next step of management, Dr. Pratima?
So basically, what if we have facilities, if we can do a HPV genotypes to find out what are the high risk genotypes, and based on that report, then we can further after triaging, then further we can do a colposcopy, and then after colposcopy guided biopsy, we can further treat the management. So
Right.
basically, I would do a screen, then triage and treat approach in this patient. But whenever the infrastructure is not there, we can just do a via. That is also possible by directly HPV DNA detection. You can also directly do a screen and treat. But in my this thing, I would definitely prefer to do a triage and then treat accordingly, whatever the condition is.
Very right. So, absolutely right that we have to go for a triaging, and triaging can be done like with genotyping, like you're saying, or with via cytology, colposcopy. So, for this woman, triage with colposcopy was done. And so, just briefly, we have always been talking about it. So, colposcopic nomenclature and scoring, what do you use at your center? What exactly are you using? Are you using IFCPC?
Yeah. Definitely we are using 2011 IFCPC classification, and so we just see whether whenever we're doing colposcopy, we have to just see whether it's adequate or inadequate by looking at the transformation zone and visibility, whether there's inflammation or obscured by any bleeding. General assessment whether it is atrophic vagina or inflamed or any infection or ectropion, and then we will directly do a colposcopy, and then if
And do
the
you do the
visibility of
sweets? Right, sweet score also. Do you?
yeah sweet.
Okay. So
So
this
we do.
patient had a colposcopy, and these were the findings, and the final sweet score was 6. So what will we do, Dr. Pratima? She is a 71-year-old lady and sweet score of 6.
So seed score of Swix basically it tells it can be a CIN2 or a CIN3 lesion. So
Right.
we will take a biopsy, and based on
Okay.
the biopsy, we do a further management. So
Yeah.
in this biopsy, if it is CIN2, so
Yes.
management is little tricky because she is postmenopausal, 71 years. So if
Yeah.
we are doing any of the procedure like LEEP or conization, we have to explain the patient or ablation. So based on her condition and based on her whether how she is accepting the procedure, based on that we can convince her, and then we can do the further management. Either it can be a thermal ablation or ablative, or it can be a conization or a hysterectomy. So I have personally faced such things in my during my this thing career. So patients do come to around 60 years, and they come with these complaints, and then especially when they're LSIL and PAP is HPV is positive. So in such patients, we do conization or a leap, and then after the conization, because of the postmenopausal cervix, they get atrophied, and whenever we call for them a follow up after 6 months or a year, the cervix won't be visible. Then it will be a very tricky how to do, because cervix is not visible, and then then they will ask us, and then pap smear will be repeatedly, it will be positive even after. So we don't know whether it's from the vaginal infection, or even if we tell it's from the vagina, but then they are still not clear what has happened to the cervix, because it's already buried after a conization. So such difficulties definitely we will face. So I do
Yeah, there
personally
are difficulties. I agree. I agree.
yeah.
There are difficulties in screening postmenopausal women. So, do you think there should be a consensus, or is there a consensus how to screen older age women? And by older age, we mean more than 65 years, because most of the guidelines talk till 65 years. So, how should we screen these women in 65 years of age or more?
More than 60. So most of the guidelines do say we have to stop at the age of 65 years. Only if previous three consecutive reports are negative.
Yeah.
Okay. Or patients has to be followed up if they have no any previously they are not screened, or if they had any abnormal results, then we'll have to continue the screening if we feel that their life expectancy is more than 10 years. So we can do that.
So yeah, meaning thereby that if they have not been screened adequately, then we can continue with their screening, or if they have had abnormal test results, then also we need to do surveillance, maybe lifelong, at least 25 years after that test being abnormal. So that is right. So we have to screen. And what are the challenges in screening these women?
So challenges do we face is most of them, like, pap smear, if they say L cell, there'll be most of these cells mimic the, squamous metaplasia and immature, they mimic the postmenopausal atrophic vaginitis or cervicitis. Hence, we can just, try with vaginal estrogens, maybe
Right.
up to
What
from
dose do
1.
you think should be recommended? How to ask them to apply these estrogen? For how long
So
would you ask?
So vaginal estrogens, they're in the form of tablets or they're in the form of creams or gels. So we can ask them to apply from minimum up to 3 weeks to 12 weeks, up to 3 months.
Yeah.
So then we if we are applying cream, then we can ask them to apply at least twice or thrice in a week. And then the tablet they can continually take for 2 weeks, then followed by twice weekly, that we can do. And personally, I don't have experience with the rings and thing.
Right. And suppose we are doing co-testing and PAP shows unsatisfactory, but HPV is negative. Should we completely rely upon that, or do you think we should do something else?
Irrespective of the HPV results, so if it is unsatisfactory pap smear, we have to repeat the pap smear after 2 to 3 months.
Right. So even if the HPV is negative, well, HPV negative in unsatisfactory pap smear does not mean that it is negative. And very rightly, you are saying that we have to repeat, after doing some interventions, maybe student application, we have to go ahead with the repeat pap smear. And this is a very interesting flow chart, which is given by ASCCP, that we have to go ahead, and if it persists to be unsatisfactory for 2 to 4 months altogether, then we can even go for colposcopy in those cases. So, like we discussed, negative HPV result from a co-test with inadequate cellularity on cytology should not be interpreted as negative primary HPV test and should be repeated. Thank you, Dr. Pratima. So next case scenario is for Dr. Nidhi. She's a 33-year-old lady, married for 3 years, para 3 life 3, complaining of discharge. She is a migrant who is residing in a displacement camp. This is another subset of population which we get in Delhi and many other larger cities, the migrant population. And she is complaining of discharge, cervix is firm, hypertrophied, and some camps were done and in which a via was found to be positive for her. So Dr. Nidhi, the question is for you now, that she has via positive, she's a migrant, she came with a via positive to you, we never know she'll come back, all those things. So what will be the next line of management, Dr. Nidhi?
Okay. So good evening, everyone. So as my case is from a migrant population, so in this case, the patient may not be, available again for any trials. So see and treat will be the best policy for this patient. Screen and treat. For that, screening has been done by VIA, and the lesion is positive. Now, my duty or the person who is doing the VIA has to see whether this lesion is valid for the ablative management, or you need to do a excisional one. So for the ablative methods, like the lesion should be, type 1 lesions present only on the ectocervix. There should be no endocervical extension. Transformation zone should be type 1. And there should be no suspicion of any invasive disease. I think all these characteristics, can I see the image again, Dr. Nilanchini?
Yeah, sure. You want to see? Yes.
Yeah, thank you. All the features which I have said that they are, fulfilling the criteria for ablative management in this case, as the transformation zone is type 1 and the lesion is not extending into the endocervix, the positiveness is faintly white. So that means we are not suspicion of any, and they are not abnormal vessels. The suspicion of any invasive disease is not there. The only thing, the lesion is extending from the around 8 o'clock to 3 or 4 o'clock. So lesion is a little bit completely covering the interior, but due to the new thermal ablator in which multiple application can be done, so this this is the candidate for ablative treatment.
Yes, yes, absolutely right. So she is a candidate for ablative therapy, and like you said, that maybe cryo won't work because it's an extensive lesion. But yes, thermal coagulators with multiple applications will help here. So now,
Yeah.
what are the barriers do you think they are there for screening in migrant population, and how to overcome these?
There are, I think, multiple barriers like, lack of education and information regarding these various screening methods, or I would say any health issues in these type of population. Secondly, there will be the non-availability of resources. Like in these population, the basic needs, I would say the roti, kapda and makan will be the basic needs which they are fulfilling very much with very much difficulty. So the basic health needs will be a difficult, resources for the health facility, they will be difficult for them to get. And sometimes this population, belong to a different culture, so maybe language, the communication may be a barrier for such type of population.
Right, right. So
I
there are
think
a
these
lot of
are the and what the so next question is overcoming the barriers.
yes,
So
yes,
we can do, multiple educational activities, including the community, specifically targeting these areas. If we target these migrant populated areas, we do various activities and in their own language, their culture beliefs, they will be more helpful so that they should be knowing about the what are the health facility they should be availing. Secondly, in these women, we can also promote the self sampling,
yes, yes,
especially if we talk about the screening of cervical cancer, because they may have the trust issues for any type of facility availing, going to any health facility. So if they look for any other methods before going matlab, health facility mein jaane ki bajaye, if they opt for the self sampling, they will be more better for such type
yeah,
of population.
yeah. I
I
completely
think
agree.
these are the methods we can overcome.
Yes, yes. So basically, we are talking about migrant population, but not just migrant population. A lot of population in India living in difficult terrains, villages which have no access to healthcare. These are all are the type of populations, and we have plenty in our country, which are actually a special group, and we have to treat them like a special group. And so this is what we wanted to talk about in a special group. The next scenario is for Dr. Vamsi. She is a 23-year-old lady, Nalipera, married for 2 years, discharged, wants to conceive, and PVPS, they are almost fine except for cervix is slightly congested, and she comes with a pap smear report of LCIL. So, Dr. Vamsi, this question is for you. What will we do next?
So, ma'am, nothing to panic or nothing to panic the patient. So, we would like to evaluate, first of all, like what are the causes? Like it could be generally this is as anyways white discharge. What is the cause of white discharge and all? And we would like to treat the patient, counsel the patient because she has come for something else. Now, particularly with regards to pap smear, that being LCIL, LCIL is again a low-grade squamous interpretation, so the counseling will form the primary part. So please counsel that, nothing to worry about it. Now, further, what we do about it. So since it's LCIL, we would like to again look at the cervix. Again, some people say you can go ahead and do a simple examination and look for it, or a simple like a VIA test, or you look with an colposcopy. So it depends on guidelines to guidelines, but colposcopy is not mandatory if it is between 21 to 25, but after 25 it's mandatory. It's
Yeah. So yes, so the guidelines which are there is that more than ASCUS for LCIL, we can go with colposcopy, but also here in a younger women, we can go with other triage methods. Anyway, this woman, she had colposcopy and sweet score was 8. Well, bad for her.
So again, coming to that, in my evaluation, I would have also looked at the immunological factors. Why such a high sweet score in this patient? So when I do have such a high, sweet score patient, then my biopsy becomes imperative. It's because sweet score of 8, I'm looking at not an LC lesion, maybe something more than that. So I would go ahead and do a biopsy of the lesion.
Biopsy. So a punch biopsy was taken, which showed SIN 2 and 3. And like you said very rightly, that in such a young lady, why should she come with a high-grade lesion? But she has, and she's young, and she's she doesn't have a child as of now. So what do you think? Is she a candidate for ablation or LEEP or conization? What do you think should be done for her?
So whenever we look at young females, conservation is the key. So we have been practicing in our practice also that we tend to be very conservative with the approaches which we follow. Now, coming to this question again, that she came with an LC lesion. So when we are provided with a biopsy which is CIN2 or CIN3, CIN2 we tend to be extremely conservative, and CIN3 we tend to move on to be less conservative.
So suppose she's sent to any other IHC marker or something which can help us in this young woman.
Yes. So it's a part of the protocol as per the last terminology that we have been doing regularly, P16. So whenever we have this problem, and if the P16 comes positive, it gives an indication that it's an HPV positive lesion and more towards a SIN3 status. So we would generally be a little more aggressive than a SIN2 lesion. SIN2 lesion, we tend to keep them on observation.
Yeah.
And we tend to repeat the clinical examination after 1 year. Whereas when it comes to SIN3, we do any treatment. So the treatments
we
which
have
we
to
have,
treat. Right.
yeah,
So
treatments
SIN2,
which we
like you
have.
said, we can do like dual stain is there. We can go ahead with P16, KI67. So these tests can be done and they can also guide us. Like the ASCCP guideline says that if they are negative, we can go towards follow-up. Like you are very keen on
Yes.
follow-up and absolutely right for a young lady like this. But yes,
Yeah.
if it is positive, then we have to go ahead with treatment. And in
And
treatment should be conservative.
But before treatment, we also look into particularly what we have been seen is that when we treat this young female, so we try to look whether these are because of some immunological reasons, like she's already a HIV positive or not. So we tend to look in all young females.
Yes,
And
that complete
then
workup
when
is mandatory.
yeah.
But suppose
So
we need to
if
treat her. Does this treatment, the leaps and ablative therapies and conization, do they have any effect on pregnancy? And if they have, then which one is best? Which one will have least
So
effect on pregnancy?
so we tend to say any excisional procedures will have some or the other form of effect on the pregnancy. So we tend to treat the ablative therapy is the one which we tend to be more focused on. And when we are looking at if the lesion looks more sick, like if it is a CIN3 lesion, we tend to do more of laser excisions, and that laser excision also with laser vaporization is one which we have been doing in our center. Let's say if we don't have a laser, then we more towards the ablation. And if we don't have an ablation and we go with the excision, because most of this 23, 24, they are type 1 transformations. So we tend to be very conservative and we try to take very superficial procedure.
So yeah, if the lesion is suitable for ablative therapy, we can go ahead with that. Otherwise, we can start with doing leaps and, lasers, and then maximum is, conization is very, very excessive treatment for such a young
Cone
lady.
biopsy, we generally CKC cone biopsy, we are almost abandoned or stopped in young
Abandoned, yes,
female.
yes.
Yeah.
Young
So
patient,
most of the time, either LEDs or we have moved towards CO2 laser conization with vaporization, so that we get less of margins, and we use both combined methods of both ablation and excision. So we get the biopsy also. But if you have, let's just take a superficial one, a very superficial.
Yes. So what do you think is the screening recommendation for younger women?
So screening recommendations again depends on area to area, region to region. In our country, we generally tend to do after 25 years of age, and you can move to increase. We can move as far as 21, where the United States Preventive Task Force guidelines says like you start after 21, but no HPV. Let us stick to the cytology till 30 years, and after 30 years again HPV gains as the primary.
Yeah, absolutely. So younger than 21, not recommended. 21 to 29, cytology is something which is recommended. And various measures, whatever is the availability in more than 30 years of age. So that is screening recommendation by age. And why do younger women should have a different approach?
Actually, younger women who are positive, they should be referred to the specialist centers. No, it should not be treated at peripheral clinics, because there are a lot of implications for her in follow, because we need to look at our obstetrical outcomes. We do need to be very sure, right? And so that we should not be rampant or not be I mean, like the standard fill. It should be tailored approach. So
Right.
if the lesion is very small, we might even use very selective excisions, not going for the standard excision of the whole transformation zone.
Yeah. Yes. So yes. So basically, in younger women, we have to be very, very tailored approach. We cannot over treatment, and it is not actually cost effective to screen younger women. So that is something which
Yes.
should be there in our minds. Yes.
Yeah.
Thank you so much. So the next case scenario is for Dr. Rimpi, another 33-year-old lady. She is pregnant, 10 weeks period of gestation, third gravida para to live 2. Minimal, not significant complaints, but again, she already has brought a HR-HPV test report, which was positive. So Dr. Rimpi, what should be the next step we should do for her? She has HR-HPV positive test for screening, and she's pregnant, 10 weeks period of gestation.
Thank you, Dr. Nilanjali, for having me here for this very important case scenario, screening in pregnancy. So in this case, she is positive for high-risk HPV DNA. Definitely, I will not be going her for screen and treat approach, because that will be too radical for her. I'll definitely like to triage her with one of the options available to us under WHO and our own guidelines. So
Right.
in this case, we can have cytology-based testing via triage, or even we can look at the genotype if it is she's having a high risk 16 or 18. So just for HPV high risk positive, the screen and treat direct approach will not be used. So
Yeah.
yeah, one of the triage tests can be done, which can guide the further management.
Yeah, so very right. We can go ahead with one of the triage tests and we can see if anything needs to be done. She's just 10 weeks period of gestation, and one can also do a colposcopy. So her sweet score was 4. So what should be done next? Now, sweet score of 4, would you like to take her biopsy?
Dr. Nilanjali, first of all, we all should know, I take the opportunity of this forum, that colposcopy in pregnancy is itself is a very challenging thing, especially in as the pregnancy advances. So it
Right.
has to be done by someone experienced in this particular field, not just the new ones. So it is always better to have experienced person doing colposcopy, because many of the changes, they are they are changed because of increased vascularity and the mucus and everything. So the things are difficult.
Right.
So
So,
as far as
so
this
what
case
about
goes,
screening? Yes,
in
yes.
this particular case, the sweet score is 4. That is a low grade lesion. So
Right.
my plan will be to keep her under observation. So not
Right.
for treatment, not for ablation or excision or anything, not
Right.
even biopsy, because this one is a very low grade lesion. So we can safely observe her.
Absolutely. And how will you follow her up? Like you said, you like to follow her up. How often to go ahead with the follow up? How to follow her up?
Yeah, for follow-up, I mean, there are no clear-cut as such guidelines, so various schools of thoughts are there. Some people, like this case is a low-grade lesion at 10 weeks. It's very unlikely that, I mean, it's very low chance that she's going to progress. And in our own Indian studies, one was done by Dr. Nirja and other co-investigators. Even the regression, the most of the low-grade lesions, they regress when you look at them after pregnancy.
Yeah.
So one approach is that you can just leave her alone and do the next examination after pregnancy is over, 4 weeks postpartum.
Yeah.
Or if you
Especially
are
because it's a
concerned,
low-grade lesion, isn't it?
yeah, yeah, we can safely postpone her till she delivers.
Right.
So, and in case the patient is very apprehensive or something, you can do a re-examination after like say 12 to 24 weeks, but that is not recommended.
Right. 3 months. Yes,
Better after that. Yeah.
we can do that. So, well, this one had a report, but would you otherwise recommend screening in pregnancy? And what do the guidelines say, if any?
See, in our more than screening, it's more important to counsel the women.
Yeah.
And it's more important to look at the cervix when the patients they come to us in pregnancy. That is, PS examination should be done.
Yeah,
Now,
I
coming to
agree.
screening, it has to be done with pre-screening counseling. That is more important in pregnant women, because if you are getting the positive result, then you should be ready with how to deal with it. So yes, if the woman has never been screened, she comes to us. This is an opportune time. You can offer her screening, definitely.
Yeah.
And in the ASCCP guidelines, it is said that if she has never been screened, then it should be done.
Yes, yes. And if she has never been screened, So it can be done, it should be done rather.
Of
Now,
course.
how to screen and when?
The guidelines are same. Less than 30 years, we can have, like in Indian guidelines, we are doing cytology. And after that, the HPV-based screening can be done. And it can be done like whenever she comes. It is written that whenever she comes, you can offer her screening at that time. But definitely in the second trimester will be a better time.
Yes, yes. So, like you said, that early second trimester usually is considered an ideal time for any test. And similarly, it goes for testing. HPV testing can also be done. Pap smear is something which can be done. And most of the guidelines, this whole guideline list which is there, and they say that it should not be done, usually defer till postpartum. But if the woman has not had a screening earlier, and this is the right time to do opportunistic screening, like you said, and colposcopy is something which is recommended if the results are abnormal. And
One more thing I wanted to add.
you rightly said that colposcopy has its own implications. So one has to think that how to go ahead with that, especially if there's a lesion which is looks like a high grade lesion, or in the screening it turns out to be like that. Then yes, colposcopy is something which is recommended. Well, it is safe in pregnancy. Biopsy is only and only done. Most of the
The purpose
guidelines
of
you can
biopsy
see.
is only to rule out the invasive disease.
Yes, yes.
If the
So it should only
colposcopy is
be done.
suggestive of invasive lesion, and if it is suspicious, only then.
Yes, yes, absolutely. So this is what is there, that biopsy is done only if it is a high grade or cancer which we are suspecting. And follow up, you're very right, low grade lesions, we can go ahead till postpartum. However, if it looks like a little more suspicious, we can do a 6 to 12 weekly follow up. And
Even if it is CIN2 or CIN3 lesion, it can be observed. But in case of a high grade lesion, it is better to schedule her colposcopy after 12 to 24 weeks. And that is one approach can be used. But in our particular patient, the lesion is low grade.
yes.
So
Yes, yes. So yeah, so this is how we deal with screening in pregnancy, which is another case scenario. Now, Dr. Priyanka, this case scenario is for you. This is another case, 36-year-old lady with a history of renal transplant, which was done 2 years back. She came with heavy menstrual bleeding, no other problems, but she came with a routine screening, which was suggestive of ASK-H on pap smear, and she was HPV-16 positive. So dual screening was done and both showed positive results. So Dr. Priyanka, what will we do next? Dr. Priyanka, are you there? Dr. Priyanka, if she's not there.
No, she's
Dr.
there.
Nisha
She's
also was there. She's there.
Yeah, I saw her as well. But right now, if you're mute, you can unmute yourself, Dr. Priyanka. In the meanwhile, a colposcopy is something which will be done anyways for her. So colposcopy was done for her, and we can see the pictures. The sweet score was 6 in this case. Anyways, with such a high, ASK-H on pap smear, 16 positive, colposcopy score 6. So a biopsy is something which is recommended. So biopsy was suggestive of SIN1 though. So how will we manage this patient? Well, everything being high grade, but biopsy shows SIN1. So how should we manage? Are you there, Dr. Priyanka? Anyone else can take this question.
Can you just go back to the previous slide, just one?
Yes, yes, yes.
Yeah.
And who is answering here? Sorry, Dr. Rimpi, are you there? Is this you?
Sorry to interrupt, Dr. Nilanjali, just 10 minutes, 5 minutes
Yes.
more, it's 8:20.
5 minutes is just fine.
Yeah. Thank you.
I'm sorry, I lost the connection in between.
Okay, Priyanka. Dr. Priyanka,
Am
are
I
you there?
audible? Yeah, I'm audible.
Yeah, so this woman has ASK-H and HPV-16 positive, and colposcopy was done, which shows biopsy was done, which shows SIN1. So what will we do next? High grade lesion screening, but biopsy shows SIN1, and she's renal transplant patient.
Yeah, she is immunosuppressed, and her screening result was HPV-16 positive and ASK-H. So this does not, and our colposcopy sweet score was also on a higher side. I think about 6,
So
more
you'll
than 6.
review, yes. So we have to
So I
review
will
the
review
findings
the
in histology.
because they do not fit in. I'll
Yeah.
probably review with the pathologist and my colposcopy findings.
Yeah, so
And
again, so basically, well, review and all were discordant, and a leap was performed for her, which showed SIN2. So we are short of time. So SIN2 management, we all know that if we'll have done leap and SIN2, if the margins are negative, we can just leave it like that. Even if it is positive, we can either plan a colposcopy after 6 months, repeat excision, or do a hysterectomy. So that's something which we do for all the SIN cases. But Dr. Priyanka, the question is that what are the special considerations in renal transplant patient? How often to screen, and how to follow up them after treatment?
so the renal transplant patients are more or less treated like the HIV. The data is based basically on ones who have on people living with HIV. So here we use screen, triage, and treat approach where we can start screening from the age of 25 or whenever they have been transplanted, and screening with HPV, then triage with either with genotyping or via
So
or
it is just like
cytology.
any other case, just more
Yes.
important here is that very rightly you said that it has to be more frequent. For example, the American Society of Transplant says that a PAPS or any other screening can be done even 6 monthly, especially in the first year after transplant. So this is what they say. But then there's no consensus on that, and every center has their own way of managing and screening these women. And more frequent is what is recommended by most of the guidelines, and even annual screening cytologies have been recommended by some. So consensus is not there, but yes, it has to be more frequent. So we can go with the idea that these are very, very high risk populations, immunocompromised, and we have to go ahead and screen them with HPV or PAPS and do it more and more frequently. And screening recommendation, it can be, well, anyway, cytology, HPV, and it is very important that we have to, encourage consistent participation in these population. And the best will be to have a guideline specific to that particular center where renal transplant is done, because the women are following up there anyways, and they can be screened as per the guidelines devised by them. Now, another case is a 32-year-old transgender male who has a cervix. And what is the recommendation for transgender in, well, as far as screening is concerned? So this is the question, that why transgender men need screening, what are the barriers to screening in them, and what solutions can be offered to them? Well, this question is open for all. Dr. Priyanka, you can also answer that. What is the
Yeah.
special consideration in transgender men?
So they might have some Mullerian abnormalities. They may have retained cervix in them.
Yes.
So and then that might harbor HPV infection and eventually cervical pre-invasive lesion or a cancer. So, and they are also transgender men. They can also be immunosuppressed.
Yes.
And
Yes,
they're
that's
more
right.
prone for HPV infections.
Yes.
And obviously the cultural and the stigma that they have, that they may not turn up for screening.
Yes, absolutely. So there are lack of guidelines. We don't know, the doctors don't know, the people themselves, the transgender people, they don't know, they face discrimination. There's a lot of psychological distress associated with pelvic examination, etc. So all these can lead to problems in transgender, but the lesson is that even in transgender with a cervix, we have to go for routine screening, and communication and support providers and targeted outreach can improve awareness among them and can improve the screening opportunities in this special subset of population. So just the end of it. Now we'll take a take-home message from each one of you. Dr. Jitendra, to begin with you, what is the take-home message for this panel?
Especially for high-risk population, we have to kind of individualize them, and we have to be aware of the fact that they need to be screened earlier, more frequently, and with high precision tests. And of course, importance of tries is always there with colposcopy.
Right. Dr. Rimpi.
My take home message is that definitely these special populations, they are generally tend to be neglected. So especially the HIV positive, because they are actually, we have a running clinic of the HIV positive, but hardly anybody is referred to us for cervical cancer screening. So
And there lies the importance of integration of screening services with HIV.
exactly.
Yes. Dr. Nidhi?
So in the end, point is this: the special population like pregnancy, old age, and immunocompromised. We also some centers, some people are seeing very less. So don't get frightened that what to do, what whether our guidelines will be effective or applicable to these population or not. If the guidelines are different, definitely they have to be more frequently screened. So every in the guidelines have given the points regarding these population, so they will be effective.
Yes. Dr. Vamsi?
Well, my only thing is that young females, they are fragile. So just because we have a guideline, just don't go and do a big leaps. So be very conservative when you're dealing with young patients who have got positive results. So be very careful and take second or third consultations too.
Yes. So Dr. Vamsi, we completely agree to your concern about not doing over treatment for younger women. Dr. Pratima?
So I feel basically for every HIV OPD or HIV clinic, we should have an obstetrician or a gynecologist who have to look every person who is coming has a to a clinic for HIV clinic. Every person has to be early pelvic examination and a pap smear or HPV test has to be done. And also most of the time in clinical guidance, we are just mentioning every woman has to get this pap smear test done. But there is miscommunication. We are not much of mentioning about the transgender.
Yes.
So there in the gender, whenever we are making guidelines, we have to make that every woman and a transgender men, in that way we feel right, it will be more of a approachable.
Okay. Yes. So Dr. Priyanka?
I think choosing the right screening method and then making sure that they come for your follow-up and adherence to the treatment, because if they are tested positive and then they have to be um, uh, counseled that they'll have to be they have to come for proper follow-up and proper treatment. That's what I feel is most of the times neglected, because they don't the compliance rate for and the colposcopy follow-up rate or the treatment is most of the times where we lack in our scenarios.
Yeah. So from all the esteemed panelists, all the take-home messages are very well taken. And with this, we come to an end of this panel discussion. Thank you.
Thank you.
So, thank you very much, Dr. Nilanjali, and all the panelists. It was an excellent discussion and such good take-home messages for every case. I think you really did great justice to all the cases, Dr. Nilanjali. Very nice cases, and to all the panelists, very good take-home messages. And we all we are really learned after this webinar. So, and Dr. Seema's talk also is very enlightening. So the whole webinar was very well attended. We had more than 100 people joining in today. And so we're thankful to the esteemed faculty. It is you who makes the webinar. And that is why people join in, because they know that they will have always the best of best messages and case discussions and very interactive chat box also. We were all chatting. So while you were also telling those cases. So I think it was great, and special thanks to Dr. Jitendra. He has joined all the way from Nepal, and thank you for being a part of this for this. And we will have more interactions with you in future. Also, we can have more international exposure also in this in this webinar. So again, I think Dr. Aruna, we can just close the message, close this webinar now. So again, on behalf of ISCCP, we would like to thank all the people who attended the webinar today and who had such an interactive discussion going on in the chat box, all the faculty, the Dr. Seema, all the chairpersons, Dr. Seema, Dr. Sumita, Dr. Anjana, Dr. Nilanjali, the excellent moderation, all the panelists, Dr. Rimpi, Dr. Priyanka, Dr. Pratima, Dr. Nidhi, Dr. Jitendra, and Vamsi. So thank you very much. And Dr. Shireen, thank you very much for a seamless execution of as the Master of Ceremony today. And we all again look forward to our next month, 7th October, 70 minutes, 7 p.m. So we'll have a very interesting case discuss. We have a very interesting webinar by Dr. Anshu Patodia and her team, and they will be doing discussing on fertility sparing management of CIN. So we look forward to that webinar also. Till then, goodbye, good night, everyone. Thank you for joining on the Sunday, and thank you very much. Bye bye.
Thank you,
Thank you,
everyone.
Bindya ma'am. Thank you.
Thank
Thank
you.
you. Thank you
Bye-bye.
so much.
Bye.
Bye-bye.
Thank you.
Thank you.